Good day to my lecturers, supervisors, and examiners. I'm Shivashni Silvanathan, a third semester student of the Masters in Molecular and Genomic Medicine in IMU. My presentation today for the Bioinformatics module will be on clinical bioinformatics, bridging bench to bedside in molecular medicine. In my slides, I hope to show what clinical bioinformatics is, how it turns raw molecular data into decisions for patients at their bedside, and I'll also zoom a little into oncology with one of my own EGFR mutant lung cancer patient in National Cancer Institute, Putrajaya. And I'll end with where the field is going and maybe why physicians should use these platforms, these bioinformatics platforms as well, and not just scientists. So these are my focus. What is clinical bioinformatics? How it changes care, with a little bit extra focus on oncology and the future directions of clinical bioinformatics. So what is clinical bioinformatics? Clinical bioinformatics applies computational methods to generate evidence for patient care. The, the workflow is complex to say the least from my point of or my perspective. It starts with acquiring and managing data, DNA, RNA, proteins, metabolites, and then we analyze it with standard pipelines. We annotate it and interpret it against trusted knowledge bases and report concise findings which the clinicians can actually act on. So the goal is basically to turn raw measurements into reproducible, defensible decisions. So this is a journey that translates the data to bedside decisions. A journey which I think many and even me has the clinician is not really aware of until for me until I started on this course, and I become aware of the actual process which takes place before the groundwork of treating patients. So it starts, of course, with patient consent. Nothing can be done without patient consent, in respect with patient autonomy. So there's always a person or human behind data. So once we have consent, then a sample can be obtained. Not just a sample, it has to be the right sample, tissue block or blood for circulating DNA, for example. And then you go into your wet lab QC, so check quantity and quality, fragment size and controls. Failures at this point will waste time later on. Then we pick the measurement, pick the assay that answers the question that we're looking for. So if it's genomics targeted panel, which is common for use in clinics, and then a whole genome sequencing or RNA sequencing for fusions, or metagenomics, proteomics, metabolomics. When it comes to infection, maybe things like phenotype. Next, we go to compute. So this row is the bioinformatics core. After pathology and vet lab has produced raw data, bioinformatics run a validated version-controlled pipeline. So in other words, the pathology says this tissue is viable and is rich with tumor. And then your bioinformatics says here is the variant and here is how we derive them. And here is proof that the pipeline was valid and reproducible. Next is interpretation, where there's annotation and evidence level. So this is where biological or clinical context is added to the data. And then we can have tumor boards or molecular tumor boards or multidisciplinary review, which documents the decisions, the limits of the test, and they come up with a plan. So basically, the annotation turns a string of bases into therapy relevant statement, and an MBT makes it actionable. And then you go to on the ground, action on the ground by clinicians. So then they're able to make an informed diagnosis and then choose the therapy, evaluate risk, monitor or undertake surveillance for the patients, and finally trial matching and also putting back their data of their journey into databases so that future patients can benefit from them. Okay, so what are the bioinformatics methods, which in a very brief view, we start with trusted sources or databases. So these are references and raw reads, for example, from NCBI, where we get prevalence and also prevalence and co-mutation patterns from Cancer Genome Atlas, oncology assertions from Cosmic. So all this sets prior probability and tumor type specificity. Next, we layer the meaning. So UniProt for curated protein function, ProSite to see conserved domains and motifs. Then we go into similarity and alignment. So basically, this is to find trustworthy comparators. We check what it resembles. So BLAST to find homologs templates, then a multiple alignment tool with Trussell Omega to see conserved residues. So this guards us against chasing mere artifacts. Then we go into structure. We go 3D. We obtain the structure from PDB or PubChem, and we examine the pocket in PyMol. Which residues could a ligand touch, and what would our variant disrupt or help binding? Then finally, the exciting part of docking, where you test the fit on Autodock Lina, and you see the interactions on Flip. So we dock the candidate ligands and then Flip to see the interactions. So we keep the chemically sensible ones and not just the good scores. Finally, after all this, back to clinic. We make it actionable. We map the finding to evidence, and we can write a tiered statement with limits. So that's how from database to biology to alignment, structure, docking to a decision which a clinician can defend. So these are the direct facets of patient care which bioinformatics influence. So the first one is even before treatment is diagnosis. We use sequencing to classify the disease and to confirm drivers, or in rare disease to find the gene that explains the phenotype. For cancer, that means calling variants on a validated pipeline and reporting them with clear tiers so that the label is accurate and reproducible. Okay, after diagnosis, therapy. We map the variant to evidence and decide the eligibility for targeted therapy. And we also screen for resistance mechanisms. So the report should tell us what level guideline is this? Is it supported? And is there any resistance markers that pushes away from a drug or toward a combination drug? And then we have surveillance. After treatment or after surgery, we use, for example, circulating DNA to see for remission or relapse and to monitor response. The key is a rising molecular signal triggers imaging or a change in therapy even before symptoms can tell you so. Finally, we translate the report into trial matching using molecular criteria, and we also feed these outcomes back into registries. That closes the loop so that today's cases can improve tomorrow's evidence. Okay, now I'd like to share one of my patients from the National Cancer Institute of Putrajaya. She's a 59-year-old female with a history of hypertension and chronic kidney disease, or known as CKD. She was a stage 4 CKD, and she presented with a persistent cough to the primary doctor. So I think we saw her around almost 10 years ago. So when she came to us, she already had a CT thorax done at the primary center, which revealed bilateral irregular lung nodules. So a CT guided biopsy of the left upper lobe nodule was done, and a wedge resection of the right upper lobe nodule was done. Both of these confirmed invasive non-mucinous adenocarcinoma with EGFR mutation at exon 21, which is one of the most common mutations seen in adenocarcinoma of the lung. To stage the patient, a PET scan was done. So the PET scans showed no distant metastasis, but there was nodules in both the lungs. So staging confirmed a T2, which is tumor 2, node 0, there's no lymph nodes involved, and an M1A disease. M is for metastasis. So metastasis is because it's gone to the contralateral lung. So this deemed her a stage 4, which is the final stage of cancer, a stage 4 disease. So historically, this patient would have received chemotherapy, systemic chemotherapy, but however, with the advent of uh, molecular medicine and bioinformatics, given that she had an EGFR exon 21 mutation, the patient was started on a tyrosine kinase inhibitor, or TKI. It was a first generation TKI called gefitinib. Okay, so this was started in July 2016. So she had follow-up CT scans every year, 2017 and 2018, which reveals stable disease. However, like a lot of patients, she did not have a smooth journey. In 2019, she had infection. She had a bronchopneumonia complicated by a worsening chronic kidney disease. So the chronic kidney disease worsened to an end-stage renal failure level. She was admitted for 2 weeks during this whole course of illness, during which only the 2 weeks the gefitinib, or the tyrosine kinase inhibitor, was stopped. Upon discharge, the patient began regular hemodialysis, and she was continued gefitinib at the same dose. So subsequently, we continued surveillance. The only thing is the modality of imaging changed from CT scans to X-rays, because she was not eligible for contrasted CT scans because of her underlying end-stage renal failure. So we performed 2 monthly chest X-rays on her, which continued to show stable disease. Her latest follow-up in August of this year, a few months ago, the patient remains ECOG-1, which shows that performance-wise, lifestyle-wise, activity level, she is fit, and she has no lung symptoms, and she has stable disease on her chest X-ray after 10 years of treatment. A stage 4 disease of lung cancer with underlying kidney issues. She remained fit and healthy after 10 years of treatment on a first generation targeted treatment. So this is her CT scan at diagnosis, which showed 2 nodules, one at the right lung, one at the left lung, and this is her latest chest X-ray. You can see that the right lung does not show any visible disease, and the left nodule is still there, but it's stable, not increasing in size. So this, when we look at our RACIS criteria to show whether it's a stable disease, she is indeed stable disease with no any progression in her cancer. So her response is far exceeding the typical progression-free survival and overall survival of gefitinib in patients with EGFR mutant lung cancer. So the median progression-free survival in pivotal trials like IPAS trial and NEJ trials for first-generation EGFR TKI is approximately 9 to 12 months for progression-free survival, and overall survival is around 20 to 30 months. As you can see, 10 years, and these figures are, there's a huge gap. So this highlights the importance of molecular profiling using multi-omics approach in identifying unique genetic factors in patients. So she was started on gefitinib based on profiling her as an EGFR mutant lung cancer patient. But why did she survive without progression of disease much longer than the expected duration? So this is where we need to combine genomics, proteomics, transcriptomics to see for deeper understanding on how some tumors evade resistance and adapt to treatment. So there are many studies already done. For this particular patient, of course, she's in the government setting. There was no any further tests done. But for the future, patients like this, or we call them exceptional responders, these patients should be profiled to see that what makes them stand out, what makes these outliers respond so well to certain treatment compared to others. So there are studies like the NCI Exceptional Responders Initiative, where distinct genomic alterations like DNA repair defects and certain targetable mutations were found, and it was associated with unaccepted durable responses. Another study by Belusic et al. Showed that molecular profiling using techniques like whole exome sequencing and RNA sequencing revealed 87.5% of exceptional responders had EPHA5 mutations, and many showed changes in DNA damage repair pathways. This led to a pro-inflammatory state and effective anti-tumor immunity, possibly contributing to outlier outcomes. Besides these studies, currently there's an ongoing multi-center study. It's called Rosalind, and it's based in the UK. So they are pioneering the creation of an extensive multi-omics database of cancer outliers by molecular profiling exceptional survivors in some of the most aggressive cancers. So, what does this mean locally? For example, in Malaysia setting, in a cost-restrictive healthcare setting, so where access to newer, more expensive targeted treatments are limited, molecular profiling can help by identifying patients who are likely to respond well to older, maybe even cheaper generation treatment. So by identifying and starting suitable patients on suitable, effective, lower cost therapies that can provide longer term disease control, you're not just improving patient outcomes, you're also optimizing resource allocation and you're minimizing expenditure on more expensive treatments. So in this context, personalized medicines becomes not just personalized but also sustainable. So that was oncology. I think bioinformatics goes far beyond oncology, like in infectious disease, rare disease, pharmacogenetics, and population health. This is a call to action for physicians, so to be platform literate, uh, to be platform literate, ask for tiered transparent reports, participate in tumor boards and also multidisciplinary reviews, and partner with bioinformaticians so that we can all make better informed choices and decisions for the sake of our patients. Thank you very much.